Okay, so here's a case study, which I only put this in because this is really a rare, quite rare presentation of a seizure, but it was a question on the shelf exam, so I thought, okay, well, let's make a case study out of it. So here's a 62-year-old man that complains of 1 year of recurring spells of leg shaking that last 1 to 2 minutes without loss of consciousness. More recently, he feels that his gait is clumsy and of urinary incontinence. Came to the emergency room after a leg shaking episode that led to shaking of his arms and loss of consciousness. Took him about 25 minutes to regain consciousness. His neurologic examination reveals hyperreflexia in both lower extremities with clonus in both feet. An MRI of the brain is shown. And so anytime if you're shown an MRI or CT, like for board exams, if it's a nice homogeneous mass like this, not an ugly, but just kind of one solid mass, that is a meningioma. Okay, obviously there's a differential, but most likely it's a meningioma. So here we have a meningioma growing, and it's compressing the paracentral lobule on both sides. And so that's why the seizure activity in this case is bilateral leg shaking. Okay, these are focal, partial simple motor seizures. Okay, and the patient does have hyperreflexia in his legs and clonus because of the upper motor neuron manifestation of the mass effect right there. Okay, so how would we classify this? Well, the leg shaking episodes without loss of consciousness would be partial simple motor or focal aware seizures. But then he had one where it spread throughout his entire body, so we would call that a secondary generalized seizure, or, new terminology, focal to bilateral tonic-clonic. So the MRI scan reveals a meningioma, which perfectly explains the patient's symptoms, and the treatment here is really going to be to remove that meningioma, to remove the mass effect, and the patient could have a very good improvement. So before we get to seizure medications, let's talk about EEG. So you need to know what generates the waveforms on EEG. That's probably the single most important takeaway from EEG. And so the waveforms that we see on EEG are from the inhibitory and excitatory postsynaptic potentials. So remember, a neuron, it gets all these inputs from other neurons, and these can be excitatory, they can be inhibitory, and those potentials are what generate the waveforms, not the action potential. Okay, these excitatory and inhibitory postsynaptic potentials are very slow in action, and that contributes to the waveforms. When the neuron discharges and we get an action potential, that's very brief, and that contributes almost nothing to the waveforms. Okay, so here we have a neuron, lots of other input. So these can be inhibitory, these can be excitatory, and that may trigger an action potential. But just remember, it's the it's this inhibitory excitatory that is determining whether the brain waves go up or down. And so an EEG will bring the patient in, usually for like an hour, and we can watch for brain activity. We do not need to catch someone having a seizure in order to be able to see the epileptiform activity. Someone that has like a focal seizure, you can still see some sharp waves even when the patient is normal. We can send a patient home with something like this to monitor brain activity over days. Okay, and so EEG activity here goes into a computer, and then we can look at these waveforms. And so remember, one of the things EEG is really helpful for is to put us in a big category. Are we dealing with generalized onset seizures? Are we dealing with focal onset seizures? And so if we see this sharp activity occurring everywhere throughout the entire brain, it's a generalized onset seizure, and we're going to need to use a certain type of medication to treat that. If we see focal seizure activity just in one area of the brain, okay, then we're going to use a different set of medications to treat that type of seizure disorder. Okay, so overall, in patients that have epilepsy, don't be surprised if you get a normal EEG. So kind of the yield is, when we do one EEG, we've got about a 50 to 60% yield, but by the time you do 3 EEGs, our yield is close to 90%. So you'll often see us repeating these studies to try to detect something. So again, EEG is really helpful. Is it focal? Is it generalized onset? And it's really helpful for our non-epileptic spells, where video EEG is extremely important. As you know, you can see the event, you can see the brainwave activity, and obviously the technology has improved a lot from these old 25-year-old videos that I just showed you. Okay, and there are actually a bunch of newer things to talk about, but we better move on here to anaconvulsants. So there are a lot of different seizure medications. When I was a medical student, there were 4 to know about. And if we were to cover all of the seizure medications now, we're getting close to about 20. Okay, so I have just, believe it or not, this is the compressed list of what I think are the high-yield seizure medications. So we have medications for the partial or focal seizures. And so all of these categories that we've been over. And so we have the older medications, and then we have the newer medications. I actually have a neurology textbook that classifies them by old, new, and new. It's the classification system. But these are the ones that I was told about as a medical student. Really easy. Just had to know about 4. So these are our older ones. And now we have these newer seizure medications that are also effective. And I put 2 asterisks here by these 4 these medications because they really only work for the focal onset seizure disorders. And I'm just recognizing here that these 2 medications also only work for the focal onset seizure disorders. So put 2 asterisks by carbamazepine and phenytoin. That was my mistake. In terms of generalized onset seizures, high-yield board here, ethyl is the drug of choice for absence seizures, and that medication is only used for absence seizures. We don't use it for anything else. Okay, but we can see that for the generalized onset seizures, valproic, lamotrigine, topiramate, and levy teracetam, these medications all are effective when we have a generalized onset disorder. Okay, so you need to know the mechanism of action. And as a big picture, there are some exceptions, but medications that work for the focal onset seizure disorders usually act by inactivating the voltage-gated sodium channels. That tends to quiet down the excessive electrical hypersynchronization that's going on in the brain. Or they may act by enhancing GABA, which makes sense, an inhibitory transmitter. We enhance the action of that. That's going to tend to suppress seizure activity. In general, medications that work for the generalized onset seizure disorder act on voltage-gated calcium channels in these in the thalamus, those thalamocortical relays that are overactive in the generalized onset seizure disorder. So that's a big picture. We'll see there are some other mechanisms of action. All right, so Victoria Burkhart, who's now here doing a psychiatry residency, made this great drawing where in one picture here we can see all the seizure medications and where they act. And so you can see that there's a bunch of medications that act on sodium channels, again, to reduce excitability. We have some medications that act on the calcium, voltage-gated calcium channels. We can see levetiracetam, which is a really important one for you to know about. It's one of the most commonly prescribed nowadays. Actually acts by blocking excitatory neurotransmitters like glutamate from getting into the vesicles. So you decrease an excitatory neurotransmitter. We have some that block the release of glutamate. We have other medications here that act against a glutamate receptor, the AMPA-A receptor. We have other medications that act as a GABA agonist to enhance GABA activity. We won't talk about this one, but we have another medication that inhibits the enzyme that breaks down GABA, so you have more GABA. So it is a lot to know, but let me just highlight a few of them before we get into them in detail. Notice that topiramate, which is a very important one for you to know about because it's used all the time. Remember, it's a migraine headache medication, often used for migraines, and it's also a good anticonvulsant. Topiramate does lots of things. It acts on the sodium channels. And so remember, any medication that acts here, it works well for the focal onset seizures. But it also acts against glutamate receptors, and it also enhances GABA. And so anytime you have a seizure medication that has multiple mechanisms of action, it tends to be broad spectrum. And so topiramate works for both the focal onset seizures and it works for the generalized onset seizures. The other one that has just multiple mechanisms is valproic acid, another commonly used medication. So it also acts on the sodium channels. It acts on the calcium channels. That makes it effective for the generalized onset seizure disorders. And it also acts down here to enhance GABA. So it does a lot of different things, so it's broad spectrum, works for all seizure types. So when we're done with this lecture, go back and spend some time with this overview slide. So phenytoin, and you only need to know the generics for now, but once you get into the third year, you'll only hear about Dilantin, but for now, phenytoin. This only works for partial or focal onset seizures. And this is still, it's a very old medication, but it's still commonly used. And so this acts against the sodium channels. So again, that reduces neuronal hyperexcitability. Metabolized in the liver, it's a strong enzyme inducer, which is important to know because it decreases the concentration of other medications. And I just highlighted here oral contraceptives. So that's important to know. There could be some effect there. And important medications like blood thinners, warfarin. And so if we're going to use phenytoin in a patient who's on warfarin, maybe for atrial fibrillation, we're going to have to really monitor the patient's, the blood thinning effect of warfarin to make sure we're not, impacting that. So it's highly protein bound, which means we tend to get a lot of interactions with other medications. So it has a 24-hour half-life, so kind of roughly, once you start a patient on phenytoin, you could 5 days later or so check a blood level and see if you're getting into a target range. And so phenytoin has a really unique property here in that its metabolism, the enzyme, eliminates phenytoin by first order kinetics until the enzyme becomes saturated. And once the enzyme becomes saturated, then we can get this point of saturation is reached here, where now the blood levels can just skyrocket exponentially. This really only happens with phenytoin. So practically, this is what this looks like. We're giving the patient this dose here. Let's say this is 300 milligrams. You don't need to know the dose. And we want the patient to be maybe up in this range. We have a normal range. We know about what blood levels should be at. So the patient is too low. And so we increase the dose, and at some point here, the enzyme metabolizing Dilantin became saturated, and so the blood levels skyrocket. So patients that are on phenytoin, even with a small dose adjustment, once you reach that point, can become toxic on phenytoin. So this is one reason we really don't like to use phenytoin that much, because this happens so easily. And when patients are toxic on phenytoin, they feel miserable. Okay? So we do use phenytoin a lot, though, for patients that are in status epilepticus. And something I would do as you go through the handout, you want to remember which medications can be given intravenously and which ones cannot. Because the medications that can be given intravenously are in our armamentarium of how we can treat status epilepticus. And the form of phenytoin called fosphenytoin is like one of our first line treatments for status epilepticus. This is the main reason that I will get a patient on phenytoin is when they're in status epilepticus. The fosphenytoin form just allows us to infuse it like 3 times faster. So that's why in status epilepticus we use fosphenytoin. So when someone is toxic on phenytoin, it affects the cerebellar vestibular circuits. So patients feel drunk, they feel ataxic, they have nystagmus, vertigo. It's a miserable feeling. And so if you go back to one of our first lectures when we were talking about nystagmus, I listed phenytoin as a medication that can cause nystagmus. So when you have a patient on phenytoin that has epilepsy, one of the things you should check on a follow-up visit is just look at their eyes. Okay? If you're seeing nystagmus, then that means you're probably giving too much phenytoin. And so you better send the patient to the lab and see if maybe they're getting toxic. StevensJohnson Syndrome and TEN syndrome can occur, although not as common as some other medications. Toxic epidermal necrolysis. And when we give rapid IV loading for status epilepticus, there is a risk of triggering a cardiac arrhythmia or sometimes hypotension. So I've seen that a few times. All right, so as I understand it, the distinction between Stevens-Johnson and the TEN syndrome is the degree of skin detachment. So if we have less than 10%, we'll call it Stevens-Johnson syndrome, and then obviously more severe here. So not real common, but you would want to warn patients if they're having any kind of skin changes, then we obviously need to get them off of the phenytoin. Okay, here's high yield board question, phenytoin, because it's uniquely can cause gingival hyperplasia. And so it's really important, two things. When you put someone on phenytoin, they need to have really good dental hygiene. They need to have their teeth cleaned regularly. That'll reduce the incidence of this. And really important, it was found maybe 10 years ago or so, that if you give folic acid with phenytoin, that dramatically reduces the incidence of gingival hyperplasia. So I only prescribe I always prescribe folic acid whenever I put someone on phenytoin. Can cause unwanted hair growth. If you go back to our peripheral neuropathy lecture, it's one of the medications known to cause peripheral neuropathy, and it can decrease bone density. And so this is a pretty impressive list of side effects. And when we go over the newer seizure medications, you'll see there are much fewer side effects. And so that is why really, if you're going for an initial treatment with an anaconvulsant, come down and ask me later your question, just because I want to try to get through as much as I can during the next little bit. So if you're choosing an anaconvulsant and you know this patient's going to need to be on it for decades, why choose one that can cause reduced bone density and peripheral neuropathy and so on? So that's why it really should not be our first choice in most cases. So carbamazepine, another very commonly prescribed seizure medication. Like phenytoin, it only works for partial onset. And in fact, if you give this medication to someone who has generalized onset, like primary generalized epilepsy, it can actually worsen the seizures. So that's why our diagnosis is really important here. Okay, pretty much the same mechanism of action as phenytoin, but yet they do work a little bit differently. It's also an enzyme inducer, and it's highly protein bound. Okay, side effects though, the unique side effects I highlighted here in yellow. So you definitely need to remember these two. With carbamazepine, aplastic anemia, which means we need to monitor blood counts every 3 or 4 months, make sure those are not going low. And I think this would probably be the higher yield board question is SI-ADH. And so this can trigger hyponatremia and other symptoms from that. And so important here, if we have someone on carbamazepine, we do need to be doing some regular blood tests to check for these side effects. Okay, this is more likely to cause Stevens-Johnson and TEN syndrome than phenytoin, and especially in individuals with an Asian ancestry. And so really we do not start carbamazepine in those individuals without first doing some genetics testing, because if they have this allele, then they're really at a high risk for developing Stevens-Johnson syndrome. Okay, carbamazepine is not available in IV form. So this is an oral medication, but it's not something we could use for status epilepticus. Okay, phenobarbital is an older seizure medication. It acts on GABA receptors by increasing the duration of the response. So get more chloride entering, more inhibition. Okay, we do not use this anymore to treat, or I should say rarely, as an oral medication to treat seizures. This is pretty much only given now for status epilepticus because it can be given intravenously. Okay, it has an amazing 96-hour half-life. Okay, so when you start someone on a medication, it takes 3 or 4 weeks before you're getting into a steady state. And one of the reasons it's not used much anymore is it just is not as effective as most of the other seizure medications. It tends to make people feel sleepy and sedated, and especially in kids, it can cause exactly the opposite. It's a sedating medication, but yet the child is hyperactive, so that can happen. Okay, so acute toxicity also kind of looks like phenytoin toxicity, nystagmus, drunk, dizzy kind of a feeling. Okay, primadone, you do not need to know is an anaconvulsant. I just include it here. Primadone's an older anaconvulsant. It gets metabolized down to phenobarbital, but you do need to remember that as a medication for essential tremor. Remember, primadone and propranolol are the 2 medications for essential tremor. All right, valproic acid. This is another older seizure medication, but it is used all the time, I would say especially by psychiatry as a mood stabilizer. So many patients at the VA hospital are on valproic acid, and it's that one of those medications I mentioned that has 3 different mechanisms of actions. It works on the sodium channels along with phenytoin and carbamazepine. It works on these calcium channels. And remember, anytime you see that, you'd be thinking about the generalized onset seizures. And it elevates GABA levels. Okay, and so it's broad spectrum. It works for partial and generalized onset seizures. So it's an enzyme inhibitor, so it can increase the concentration of other medications. And later on, we will talk in a few minutes about lamotrigine. And there's a very important interaction between valproic acid and lamotrigine. So if we ever use these 2 seizure medications together, we just need to be very careful. Okay, so it's broad spectrum, and it's available in IV form, so it's another medication we can use for a patient in status epilepticus, but the side effects are really significant. So let me highlight the ones that I think would be most important for you to know. First of all, tremor and even Parkinsonism is common. And so this is not really through a dopamine mechanism, but whenever I see a new referral for tremor, if the patient's on Depakote, it's almost certainly the Depakote that's causing it. So it can cause a very significant tremor and can even cause someone to look like they have Parkinson's. A lot of these seizure medications cause weight gain, but this is the one that causes the most weight gain, so it can be quite dramatic. Years ago, I remember starting a mentally retarded girl on Depakote or valproic acid, and saw her back 6 months later, had gained like 40, 50 pounds. And so it certainly is not a medication we'd want to use, in someone who's obese, so that can be a significant issue. It can cause a fatal fulminant hepatitis. Now, these are usually kids that are on multiple anticonvulsant medications, but we certainly would not want to use this in a patient that has a underlying liver condition. And overall, if you put someone on valproic acid, about 40% are going to have an elevation of their liver enzymes. Okay, it can cause an acute pancreatitis. Okay, I recently took my 10-year neurology board recertification exam, and that was a question they had on there for neurologists. So it can cause a pancreatitis. Okay, and probably one of the most important things, in fact, probably the most important, is neural tube defects. Of all seizure medications you could put someone on, a woman, this would have the highest incidence of causing neural tube defects. So really, you should not use this medication in a woman that has epilepsy that needs to be put on a new medication, because she may tell you, there's no way I'm going to get pregnant, but you don't know what's going to happen 5 years down the road, right? So we have other options that would be just as effective. So just recognize this is the highest incidence of neural tube defects. Okay, so it's highly protein bound, And so the other medication that interacts with valproic acid is phenytoin. And this is a little bit complex here, but valproic acid can displace phenytoin from albumin. And this is really kind of a lab thing, because we can use phenytoin and valproic acid together. Maybe we've got a patient with a really refractory epilepsy. And what can happen is you see the patient, and it looks like they're phenytoin toxic. You know, they've got nystagmus, they're staggering all over the place, and you get your phenytoin level, and it's normal. And you're confused about that. How can that be? Well, just to realize that when you measure a phenytoin blood level, you're measuring the phenytoin that is bound to protein. And since valproic acid displaces phenytoin from protein, whenever we have a patient on this combination, we need to get what's called a free phenytoin level, because this will also measure the phenytoin that is not bound to protein. Okay, so it's just kind of a lab thing, just to recognize that we need to do free levels, phenytoin levels, if we use that combination. All right, ethosuximide, drug of choice for absent seizures, frequently asked on boards. Its mechanism is on the T-calcium channels. That's their underlying mechanism for most of the generalized onset seizures. It's usually pretty well-tolerated medication. Can cause a little bit of sleepiness, so we need to get the dose adjusted just right. And there are some rare reports of StevensJohnson Syndrome with ethosuximide. Okay, benzodiazepines are only used in the treatment of status epilepticus. These are short-acting medications, and so the two that we use here are diazepam and lorazepam. Okay, remember that withdrawal of benzodiazepines causes seizures. So these are not appropriate to prevent seizures. They're only for status epilepticus. Okay, and so I underlined here that these, like phenobarbital, acts on the GABA receptor, but it increases the frequency of chloride channel opening. Phenobarbital impacts the duration, and so you will sometimes be asked to contrast between the action of phenobarbital and a benzodiazepine on the GABA receptor. So benzodiazepines, these are medications used for sleep, for insomnia, and so they cause sedation, and you do need to be very careful when you're using this in the emergency room for status epilepticus. If you give too much, you can cause respiratory failure. Okay, so we need to follow the dosing guidelines carefully. So here's the GABA receptor. Okay, so we have the benzodiazepine site here, and the barbiturates, the phenobarbital. So remember the difference between duration and frequency of channel opening. Lamotrigine is very commonly used. You'll see lots of patients on lamotrigine. It's used also by psychiatry for mood stabilization. And lamotrigine inhibits release of glutamate. It also acts on the sodium channels, just like phenytoin and carbamazepine. And so that makes it broad spectrum. So it works for both partial and generalized onset. One reason you might not choose lamotrigine, it's a great medication, but it takes a long time. It takes like 5 weeks, 6 weeks from when you start the medication until you're getting into a therapeutic range. And so if you have someone that's having frequent seizures, you don't want to just wait for 5 or 6 weeks and let them go on and have seizures. So if time is of the essence, you probably would not choose lamotrigine. Okay, I mentioned that valproic acid has a significant interaction with lamotrigine, and so when we have a patient want to have a patient on both of these medications, you need to increase the dose much slower than you normally would. So you can use them together, you just have to be extremely careful. So I only tell the patients when I start them on this medication about one side effect, and that is rash. Okay, because it's otherwise so safe, so well tolerated. So about 10% will get a rash. Going on to Stevens-Johnson or TEN syndrome is much less common. Okay, but that 10%, that rash can be pretty annoying. So if they develop that, you're probably going to stop the medication and move on to something else. So if we need to start a young woman on an anaconvulsant, this would be a great choice, because there's really no evidence that this is harmful in terms of pregnancy or neural tube defects. Levetiracetam, I don't know, if I had to guess, I would say is probably the most commonly used anticonvulsant that I see today. It's broad spectrum, so it works for both partial and generalized onset. It's available in IV form, so we can use it for status. And unlike lamotrigine, when you start someone on oral levetiracetam, within a few days you're getting some therapeutic benefit from that. So that's probably why levetiracetam is used a bit more than lamotrigine, because you can start someone on this in the emergency room and send them out and be confident that they'll be getting some benefit from this right away. So the mechanism is probably through interfering with glutamate getting into the synaptic vesicles, and therefore you have less release of a glutamate. That's probably what it does. Okay, so remember lamotrigine, I only tell patients about one potential side effect, rash. And with levetiracetam, the only thing I will warn patients about is mood changes. So patients can get irritable on levetiracetam, especially if they have an underlying anxiety, depression. And so that would maybe be the one time not to choose levetiracetam. If you have someone with, quite a lot of mood disorders, that can really be worsened by levetiracetam. So one of the first patients I put this on became suicidal on it. And so it's not that we see it that frequent, but it can be rather dramatic. All right, topiramate. Remember, used all the time to prevent migraines. Works great for migraine prevention, but it came out originally as an anticonvulsant, and it's also a very effective anticonvulsant. So it works on the sodium channels, just like phenytoin and carbamazepine. Okay, it also enhances GABA activity, and it actually blocks these glutamate receptors as well. So it does a lot of different things, and that makes it broad spectrum, partial and generalized. So topiramate has a number of unique side effects, and so I've tried to highlight the ones I think you should know, but here you should know every single one of these because they're all kind of unique. So topiramate is a carbonic anhydrase inhibitor, so the most common side effect initially is numbness and tingling. And so it's important you tell patients that, because this is often something that they'll just have when they're starting on the medication. And so they get numb around the mouth or in the fingertips. And so tell patients not to be alarmed. It's probably going to go away. If you don't, then they're going to obviously be very concerned, what's happening. So that's very common. Weight loss. Really common side effect. Now, this is usually only like 7 or 8 pounds, and then things level off. I have had 2 patients where I've had to stop the topiramate because they just kept losing weight. So it kind of tricks the brain into thinking you're full early. But if you have someone who's overweight that has epilepsy, then this might be a good choice. Remember, valproic acid causes weight gain. And so we'll kind of look at the patient and determine maybe what would be the best medication for them. Here's probably the most common reason that I will stop topiramate. It can, some patients will say it just makes them feel dopey. And more specifically, it usually is word-finding difficulty, which is really interesting. And so I've had patients just say that, they want to say the doorknob over there and they just can't think of the name for it. And I had a teacher that I put on topiramate who just could not function in front of class. Just the words would not come. So this goes away when you take them off the medication. But that would be probably the biggest indication for stopping it. Can also cause kidney stones. Okay, so know these 4. And there is some rare cases of angle closure glaucoma with topiramate as well. Okay. Estradiol concentrations are reduced, so it is really important with a lot of these seizure medications that you communicate with a primary care provider as well to make appropriate adjustments. Okay, and I apologize, I'm just going to go another minute or 2 here so we get through this. Gabapentin is an extremely, so many patients are on gabapentin, but it's not used for seizures that often because even though it came out as a seizure medication, it's mainly used for pain. Now, with a name like gabapentin, it must have to do with GABA, right? Well, not necessarily. It was designed as a GABA agonist, but it may instead act on the voltage-gated calcium channels. There's still some debate about that. So I don't think anyone would ask you the mechanism because people can't really agree on the mechanism of gabapentin. But it can work only for partial onset seizures. Side effects are rather nonspecific, so I wouldn't try to remember those. But you should know that gabapentin is used for a multitude of different pain syndromes, such as peripheral neuropathy. Right? Oxcarbamazepine, think carbamazepine, okay? But oxcarbazepine is, I would say, maybe an upgrade, because although it can also cause hyponatremia, like an SIADH and StevensJohnson Syndrome, it's not an enzyme inducer, so you don't get into the issues with interaction with other medications. It's also less likely to cause aplastic anemia in contrast with carbamazepine. Remember, carbamazepine is only oral, and oxcarbazepine is also only oral. And like carbamazepine, it's only for partial onset seizures. So I should have put this together with carbamazepine in the handout, but this we're using, I would say, more often now than carbamazepine because of lower side effects. Okay, and then I'll finish with this one, leucosamide, which is, it's been out for 8 years or so, but this would be a new anticonvulsant. And so this acts on the sodium channels, just like phenytoin, carbamazepine, so it's only effective for partial onset seizures, but this one is also available in IV form. So when someone comes in for status epilepticus, you can see we have a lot of options, a lot of different things that can be used to abort the seizure. Okay, so we'll stop there, and I will see you next Tuesday afternoon.